So thank you very much, and thank you for the invite. Thank you for organizing the day, and overall, thank you for all the support that you guys give um, to all our patients and their families. As you say, I'm just going to talk a little bit about minimally invasive approaches, the relevance to cavernomas, but more importantly, the decision making in neurosurgery. I'll try and keep it short, and obviously, if anyone has any questions, then by all means, I will do my best to answer them at the end. So the objectives was to kind of look at, we'll give you guys a glimpse into, well, specifically my journey to develop minimally invasive neurosurgery at King's. I practice in both pediatric and adult neurosurgery at King's, and have done since 2014 as a consultant. Just to the different types of pathology that I deal with in terms of the minimally invasive approach, the relevance for cavernomas, as we said, the difficulty in managing patients with cavernomas, how are they managed, who manages them, who should be managed them, and the importance of trials. But you've heard a fair amount this morning, so obviously I won't dwell too much on that, and I know I'm kind of preaching to the converted here. In terms of disclosures, I had an honorarium from Medtronic for a talk on electromagnetic neuronavigation, and I also am a director of endoscopy and neurosurgery, where we organize neurosurgical international courses with sponsorship from industry. So in terms of my journey, you've heard I've started as a consultant since 2014. I started my training in 2007, and that's really where my endoscopic and minimally invasive experience started. I was fortunate to work with a few consultants who had an interest, and it all developed really from there, with a fellowship on the way, which I did in Alderhay in 2013. So the concept of minimally invasive surgery is established, and is long established, as a matter of fact. And really, it's about small incisions with potentially improved recovery. It really is relevant when one thinks of thoracic surgery or abdominal surgery, where there were often really big incisions that really hindered recovery and even impacted on outcome and survival. So it all kind of stemmed from there to an extent. And the concept really, if you're going to have a small incision, small access, the camera or your eyes are outside the body, you're not going to be able to see. So you need a lens inside the body cavity to allow visualization. It's as simple as that. And often once you have a lens inside, and especially with the improved optics that we have nowadays, the visualization is phenomenal, as long as you know where to go, where to aim, and how to do so. The difficulty really comes with instrumentation and skills. There's a huge learning curve, and often we're asking a lot of these kind of pathologies that we deal with that are deep and relatively inaccessible are often addressed by very senior and experienced neurosurgeons. And whenever there's a bit of a paradigm shift, or certainly in addition to the armamentarium that we have as surgeons or neurosurgeons, where you need people who have had established practices and established skills, there's always a difficulty in certainly convincing surgeons that this is a good approach and to take this approach on. We saw that in laparoscopic surgery. I see that also. We do some fetal neurosurgery, where we do minimally invasive fetal neurosurgery. And we know that there's a lot of resistance to those kind of techniques. They are tricky, but often you find when people train from the outset, they have a knack to be able to perform these kind of procedures. So specifically with regards to neurosurgery, it's a more recent concept. It dates back still over 100 years. And the neuroendoscopes, as a matter of fact, were used prior to even the microscope. And you heard Mr. Neil Kitchens mention briefly the microscope this morning. When one thinks of minimally invasive neurosurgery, it's not just the incision, because you're talking about soft tissue, but there's little of it. You're talking about the scalp, you're talking about bone, and then the brain. So the most important thing is to be minimally invasive when it comes to the brain, because that's what's going to give you the deficit and the defect. Of course, with tissue, soft tissue and bone, then we are talking about cosmesis, which is equally important as well, especially in areas where you've got some access that would involve parts of the face and the skull. Equipment and maneuverability and hemostasis have always been limiting factors. So hemostasis, as in controlling bleeding. As surgeons, that's what really one of the big factors that we have to do, is to be able to control bleeding. Well, avoid bleeding, but also to control any small bleeding. And because with neurosurgery, you're working inside cerebrospinal fluid, so essentially liquid, which is clear, any small amount of blood will very much affect your visibility. The complexity of tasks and potentially steep learning curve that I've just mentioned are something to bear in mind and has been limiting us in terms of minimally invasive neurosurgery. The concept itself, though, it does not equate to just using an endoscope. So the concept itself is more about just taking care of all the structures on the way to the lesion that you're trying to address, whatever that lesion is. So you could use microscope and still do minimally invasive neurosurgery. The microscope that we use are two different companies that have made microscopes that are in common use, both Leica and Zeiss. And essentially there's a big base with a screen and an arm that moves in almost every direction. And that's the kind of the microscope, the optics and the visualization system. So you've got the eyepiece here. There are 3 eyepieces normally. You can only use 2 at a time, either forward facing as you see here or side to side, and controls here on kind of almost a handlebar of a motorbike. And you can see the lens at the bottom. So you have to look down onto whatever you're operating on. So you're not looking straight ahead at your hands. And most of us, it's just innate. When you train in neurosurgery, that's what you use, and that's what we are used to using. So in terms of the journey to minimally invasive neurosurgery, it was really about having the right equipment. And I often felt like some of the pictures you've just seen, that whatever equipment I was using to try and do any endoscopic neurosurgery was very antiquated and very inadequate for the job at hand. This is one of our old disposable endoscopes. It's just merely a small metal tube with a channel. The channel is about 2 millimeters, and the optics were really poor at the time. And the only thing you could do is put a balloon inside to make a hole and make the hole bigger, so often to bypass any blockages, but also you can go in with biopsy forceps or scissors to do small procedures and small operations. When you look at this and someone asks, can you do complex brain surgery? The answer is often no. And I think that's fair. The question really for me was not, well, can we do it with this equipment? The question is, well, if we need to do it in a minimally invasive way, what equipment do we need and why don't we develop it? In every aspect of surgery, there have been needs where we've had to meet them by saying, okay, well, we need these equipments to be able to do this kind of procedure. The issue with neurosurgery is it's quite niche. The number of patients are often not as big, and therefore to try and convince companies to invest financially is tricky. So you've seen the old endoscope. The first thing I did when I started work as a consultant is just look for the biggest endoscope in terms of biggest working channel that I can find, but still the smallest external channel. So we found a specific endoscope that was 8.3 millimeters on the outside, but the inside was oval and not completely round, and 3.7 by 6.5. So you can see the oval channel here, and the lens is just at the bottom, and you can take the lens in and out. This oval channel means that we can put more than one instrument here. This is the kind of almost advertising brochure of the company that makes it, and they've put all these equipment, but you can only put 2 instruments at a time, really. But that's what we needed, because that's what endoscopy was lacking, is being able to put 2 instruments to have bimanual manipulation. So instead of just using one hand, you're using 2 hands inside. Of course, then someone had to hold the endoscope, so you had to even have more people who are experienced in using it. When it came to then equipment and hemostasis, so control of bleeding, these are the equipments that the endoscope comes with. So 2 millimeter diameter biopsy forceps. Some of the lesions I was dealing with, and a lot of us deal with, and certainly in pediatric neurosurgery, are very deep, but can be up to 8, 9, 10 centimeters. If you're taking bites with a 2 millimeter biopsy forceps, you'll be there for a week. It's not realistic to be able to expect to take a deep lesion out with instrumentation like that. But sometimes there are techniques you can use where you can try and dissect around the outside and bring a lesion towards you, but that's not always possible. With this endoscope, there were bigger forceps, but again, still tricky to do anything that's often the literature said over 2 or 3 centimeters, impossible to do endoscopic neurosurgery. We've demonstrated that's not the case, but with the right instrumentation. What you see here is the monopolar and bipolar. So that's called cautery. So that's when you use electricity to control bleeding, because it heats up and it warms and it controls bleeding. So we had the equipment. The next thing, well, suction. As neurosurgeons, we often use suckers. You have to use it when there's fluid to suck the fluid out, but also when there's any small amount of bleeding that you don't need to control immediately, that you just need to be able to certainly get out of the operative field so you can do the operation. But also we use suction to take lesions out and to take tumors or other lesions such as cavernomas. As a matter of fact, cavernomas respond much better to suction than other techniques I will show you. At that point, we did not have a sucker that was endoscopic. So I tried various things, including NG tubes, so tubes that we feed children and adults through the nose. But these are very floppy and flimsy, so it was very tricky using them. And then a company started very thin, rigid suckers that we could use, but the idea was that you just connect them to a syringe and aspirate. And we managed to actually connect them to, we have wall suction systems, and to test them first and use them. And this has really transformed everything we do. We talked about other techniques. That's an ultrasonic aspirator. So essentially, it's again the same. It's a sucker, but it uses ultrasonic waves to fragment tissue and therefore make it easier to be removed through the suction tubing. But this is a big handle, and you can see that you cannot fit this down a 3 to 6 millimeter endoscope working channel. So we looked long and hard at the time, and this is now about 6 years ago, and we found one endoscopic ultrasonic aspirator where you can put that through an endoscope. And I literally thought it was Christmas as soon as I found that, and I thought, now all my answers have been provided, and my prayers answered. So I got the ultrasonic aspirator, and I tried to fit it down the endoscope that we have, and of course it doesn't fit. So it fits down one endoscope that was discontinued, that was made a very long time ago. And the little green stopper there is specifically made to adapt to this endoscope. At which point I thought, and I had a feeling that from various things I'd heard, that the company was going to discontinue this ultrasonic aspirator. So it's quite important that we at least, either it worked and that we pushed them not to discontinue it, or that we just looked for other kind of adjuncts to help us remove lesions. We dismantled the ultrasonic aspirator and realized that actually the titanium sheath can be removed, and it's just the inside. And once you did that, you could fit it down the endoscope that we use. Of course, at that point, the equipment's been tested the way it is. So can I just take it and use it on patients? And the answer is no. So we had to test it in vitro. We had to make sure it didn't heat any fluid up too much, and it didn't cause any other trouble in any way, shape, or form. So there was a period of testing first, and then we proceeded to use it on the first kind of clinical setting. But of course, with full disclosure to say, we are using this ultrasonic aspirator. I have used ultrasonic aspirators all my life in terms of neurosurgical training and as a consultant, but we don't normally use them with endoscopes. And certainly with this one, I've had to dismantle it and use the bare essentials, and had agreement of the patient and carried on. I think the first patient we used it on was an 86-year-old lady who had a tumor quite deep, who was a phenomenal lady. Actually was swimming 3 to 4 times a week. I think I can manage 3 to 4 times a year, to be honest. And she had a good few years after that. I think she survived till she was 89, and then died of other causes. And the tumor was under control. So far, using this ultrasonic aspirator, and this is last time I checked was November 2020. And it's important that you keep checking first the number of operations you're doing, the outcomes, most importantly, and the indications, and always reconsider your practice and think, hang on, am I doing the right thing? And it doesn't matter, whether there's already a setup. Most of us have that with things called morbidity and mortality meetings, where we sit down and we talk about all the complications. And it's very important that we're all honest, of course, with ourselves and everyone else, to say, well, you know, here's my outcomes and here's what's happening, or us as a team or as a unit, here are our outcomes. And should we be carrying on? Should we invest even more in this, or should we just think of something different? So last time I looked at the ultrasonic aspirator, we had 43 patients. Now we're over 50. This is not endoscopic resections of lesions. This is purely using the ultrasonic aspirator. In terms of endoscopic resection of lesions, there's been quite a few more without the use of the aspirator. So we're coming up to probably about 75 to 100. And equal spread between males and females. And the youngest was a 5-month-old with a tumor inside the ventricles. The ventricles are chambers that have fluid within the brain. You guys may or may not have heard that term used. And all the way up to 86 years old, as you've heard just now. 51 operations using the aspirator. And the majority, because it's intraventricular in the chambers that have fluid, are for tumors or lesions that have caused hydrocephalus, hydrocephalus being fluid on the brain. We've managed purely endoscopic, so without using anything else. Gross total means removing the whole tumor or lesion, or near total is the majority of the tumor or lesion. So we've managed resection in a smaller number of the procedures. Admittedly, a lot of those we were not going in to achieve gross resections. There are lots of tumors that are benign that we come across inside the ventricles, where just taking a part of the tumor is enough to keep someone alive and well and healthy, and give them a very long-term survival. And sometimes actually in our almost efforts to take everything out, we could cause a lot more trouble. And, you know, as people say, you can always kind of live to fight another day. And that's quite important with some of the really complex tumors, to not go in for complete resection. Some of them are not, it's not possible to completely reset them, because you'd be taking normal brain as well with them, because they involve normal brain. Monoportal just means the fact that we're using a single tract. We're not going through multiple tracts. But there is a technique that we developed to get between one ventricle and another, which is called choroid fissure splitting, and quite fortunate to be in one of the 2 centers where we use this technique. There are other centers around the world that are trying it, but in terms of endoscopic splitting of the choroid fissure, it's quite unique to where we are at the moment, and where I practice. The factors that dictate the extent of resection are tumor location, the consistency, the histology, so the type of tumor, and adequate instrumentation. And this is almost the total kind of spread of histology, and you can see a lot of them are benign tumors, all the way down to malignant tumors, but also less common pathologies that you would get. And amongst those, at that time, it was the Cavernoma. It was a single Cavernoma that I've used the ultrasonic aspirator, because the majority of the ones that I've used, the minimally invasive endoscopic or tubular retractors, and I'll show you those in a second, technique, I did not need to use the ultrasonic aspirator, because they often are quite amenable to just suction without any ultrasonic kind of fragmentation. We talked about the choroid fissure splitting. This is a slightly complex drawing, but you can see the skull here on the outside. The brain, this is the cerebellum that deals with balance, the brainstem, and then the spinal cord here at the bottom. In blue is where the cerebrospinal fluid is. So these are ventricles. That's the 3rd ventricle and 4th ventricle. And you can't see the 2 lateral ventricles. So they would be 1 and 2, essentially, is one on the right, one on the left. To get between the lateral ventricles, so the ventricles at the top of the brain, the chambers, into the 3rd ventricle, which is in the middle, we've had to use the choroid fissure splitting technique. So just a couple of examples in terms of scans and what we've been able to achieve. This is a young child who was 3 years old with quite a, well, it's a massive tumor. It's one of the biggest intraventricular tumors I've ever come across, whether my own patients or others. And I think in maximal diameter was around between 7 and 9 centimeters. And this was a benign tumor, a meningioma. And whichever way you accessed it, we needed to deal with the fluid drainage. We had to communicate all the fluid chambers, and what we had to do was debulk. We had to stage this procedures. It was 6-hour surgeries, and we did in the end 3 of those. which is quite common for some of the really big operations, but normally the big tumors, but normally we'd stage it over 2 if we can. We tried the endoscopic on one occasion, and we were able to debulk, you can see here on the right-hand side, an amount of the tumor, and I would just say maybe a fifth of it. And then the second time around, we use a combination of endoscopic and tubular retractors, and we're able to take the tumor out with a very small tract left in situ. That, just having an MRI like that, is potentially, great if you're in conferences and talking about what you can and can't achieve. The reality is, how is the child at the end of it? And the child was doing extremely well. At one point, I understood from parents that she was really top of her class and not affected by any of this. We were worried about whether or not the visual tract, so whether she'll have a bit of a field defect, and fortunately she hasn't, because the visual tracts are not too far from where we were operating. And another child, a teenager, unfortunately with a very aggressive tumor that often affects, it's the second most common brain tumor in adults, but you do get them also in children. When you get them deep inside the brain, they are just a nightmare to deal with, because the outcomes are poor. Trying to get to them, let alone to take them out, can cause a lot of morbidity. So we're quite fortunate that we're able to, through a small tract, get in. And so you can see there, that's the nose, lips, that will be the tongue, and that's the back of the head. That's the brain here, and that is the tumor in the center, so in the third ventricle. And here we're looking at the brain and the head head on, so you can see the ventricles in a different configuration, and the tumors here. So the only thing I need to kind of you guys to get from this is how deep it is. It's essentially in the center of the brain, and we were able to get from the side through a small hole and debulk this. So this isn't quite a near total resection, but it's a very substantial resection. It meant that a child who would have normally survived, unfortunately, 2 or 3 months at best, was able to survive for 24 months and have a very good quality of life throughout. And for us to be able to manage everything else that goes with having a diagnosis like that with more time, and therefore in a better way. And this is now, what's the relevance to Cavernomas? I'm very conscious that I'm talking to you guys at the Cavernoma Alliance, and we've mentioned a lot of tumors. Well, the experience that we've had with that, and I've had a lot of patients that I've operated on with Cavernomas, and the challenge we'll talk about in terms of, as a neurosurgeon, in terms of managing Cavernomas is not necessarily the surgery, despite the fact that much of it is very complex. And certainly when it comes to brainstem Cavernomas, it's very tricky. So the reason I've mentioned everything I've mentioned is because my experience with tumors, in dealing with brainstem tumors and with the minimally invasive approach to very deep and inaccessible tumors, has meant that I could use that for Cavernomas. And what you can see here is a teenager who presented to us quite a few years ago now with a bleed in the top of the brainstem. The only thing I need you to get from this is a CT, so the bone comes out quite white. This is an MRI, and there are various sequences in MRI where fluid can be black or white. In this one, fluid is white in the MRI scan. So on the top left is a CT, and the bit of what we call high density, which means just white in the middle, is the bleed. Later down the line, this child was on our ITU and a high dependency unit for months, and we needed quite a bit of rehabilitation to get her back up and kind of going. And then she was back at school and did well, and we were very proud of the fact that we have excellent rehab facilities, but she just soldiered on, and she made an amazing recovery. So it was very easy at that point to say, well, you know what? This is midbrain Cavernoma. You are doing well. You're young. I need you to keep trying to achieve everything you're doing. And if you want to, always discuss surgical options, more than happy to do so. But this is very complex surgery that's very likely to leave you with a deficit, especially when the ventricles, the chambers that have fluid, were small at that point. So she did not have hydrocephalus. Naturally, you encourage second opinions, both nationally and internationally. And they went to other countries with people who have specific approaches they've described and that they very much pioneered and so on, and we've always encouraged that, and then discussed with her and the family afterwards. what happened is 5-6 years down the line, we having managed everything conservatively and very much all sold on the fact that this should not be a cavernoma that we do anything about unless there's a specific indication that could be life-threatening or something changes or we have repeated bleeds. What happened is we went from the top right-hand side scan where you could see the cavernoma. I hope the cursor you can see on the screen. If not, if someone lets me know, I can just minimize that and then hopefully you'll be able to see it. And then if you look at the image below, the cavernoma had got bigger in the midbrain. That on its own, you think, okay, well, is there anything else that we can use? You've heard about, often as neurosurgeons, we've always, there are a few lesions that we said do not respond to radiotherapy or radiosurgery, but certainly there is a slight kind of move away from just saying that and saying, hang on, or do we have proof that they do or they don't? But with this, what, in addition to the cavernoma getting bigger, it's blocked the fluid pathways. So we needed to do something to relieve the pressure. And often, you know, the most common thing is to put a shunt in, which is a tube and a valve. And often people become reliant on that. And it does mean that if this fails, you do have to revise it because otherwise you're in trouble. Other options are to go in with an endoscope and just bypass the blockage. Because we do a lot of that at King's, and I have a lot of experience in that, and because of our experience with tumors and with brainstem monitoring, we decided that actually we would have long discussions internally, but also with the patient and the family about the fact that we could go in and address this with an endoscope, even though it's the midbrain, as well as bypass the blockage. And that's exactly what we did. I mean, there were a lot of, we'd kind of almost floated the idea from the very outset to say one day we may be in a position to do this should you ever need it, but you should always go through life thinking I need to avoid surgery on this lesion that I have in my brain. And actually she was quite a bit older when we had to make that decision together, but her parents still very much involved and supported everyone in the decision-making process. What you can see here is that there is a residual cavernoma in the midbrain. We didn't go for broke. I'm very confident it was the right decision to stop short of taking that last bit out. You can see that is called flow void, that kind of black here that you can see going from just one aspect of the brain to the other. That's fluid flowing through a hole that I made just in front of the cavernoma. What you can see is also fluid flowing at the back, which you couldn't see on the scans before. And the reason for that is because we debulked, we reduced the bulk of the cavernoma. So what's happened here is that we've got a smaller lesion and we've opened all the pathways. She did need weeks of rehabilitation again to recover, but I'm very happy to say that she did reach her pre-operative baseline. So that was with an endoscope. This is another young girl who presented with a big hemorrhage in what's called the septum, which is a membrane that's between the two ventricles at the top, the two chambers that have fluid. So we said the chambers have, on this sequence of MRI, the fluid is white. And all you can see here is a big bleed, and it looks different on different imaging modalities, but certainly on that scan, that's what it looks like. Later on, when it kind of contracted, it looked more like what cavernoma would look like. Often people would say it's a popcorn kind of appearance on an MRI scan. And then what you can see here is post-resection. You can't see the tract on this. I'll show you the tract on the other scan, but there's a small residual of what's called hemosidrin, which is blood degradation products. And these are just stuck to areas called the fornices. So this is not a complete resection of the cavernoma. This is a resection of the majority of it and leaving a tiny bit left on what's called the fornices, which deal with short-term memory. The worry with this is that it was going to, if it ever bled again, it could cause hydrocephalus. And although most cavernomas, if they bleed, the bleed is, to an extent, it just resolves and doesn't tend to cause huge defects and deficits from just one bleed. Not always the case, and I've seen situations where it was even completely different to that, but these are very rare. But if it happened inside the ventricles, the worry is it was going to cause hydrocephalus. Hydrocephalus can be life-threatening very quickly. So we did address this, but again, not after one outpatient appointment. It was after multiple reviews and outpatients and discussing all the options so that everyone's had time, because once you go in, you can't undo what you've done. And the tract, you can see I always leave a little catheter in case we ever need to access the fluid, and that's the catheter going through. So it's just millimeters and everything looks back to normal. it's minimally invasive, but naturally the most minimally invasive approach is not to approach anything at all. We don't always have that luxury. Occasionally, rather than using an endoscope, and this is a 2-year-old child who had a cavernoma that had multiple bleeds. So this is easy. It's easy to make the decision, not easy to operate. It's easy because it's getting bigger. It's formed a cyst. It's affecting, it's causing seizures, but it's also causing a lot of swelling in the brain around it here. And it's causing weakness on the opposite side. So this is post-operatively, we took the whole tumor, the whole cavernoma out, and that's what we used. It's a tubular retractor. So what it does is it goes through the brain and splits the fibers rather than kind of destroying the fibers to get to a deep lesion. And then you can work through that retractor to get the lesion out. So in terms of cavernomas and the experience that I've had and that we've had at King's is pediatric and adult, and the youngest has been a 1-year-old who came in with very unwell, having blocked his fluid kind of drainage system, and we had to operate, and we didn't even know at the time that this was likely to be a cavernoma. So I've often had the kind of more exotic presentations of cavernomas, if one can use that word. They've been brain and spine, including cerebella, and cerebella can be quite unique in terms of how they behave. Brainstem, as well as other eloquent regions, so motor cortex, which is the part of the brain that controls the other side of the body. We've used the microscopes, tubular retractors, endoscopic approaches. Intraoperative neural monitoring means monitoring the electrical activity, so of arms, legs, of breathing, swallowing, and various things like that as we're operating. ECOG is being able to look at the electrical activity of the brain, because if you're doing it for seizure purposes, I am not an epilepsy surgeon, but because I end up operating on some tumors and lesions that cause seizures, it's important that I work with my epilepsy surgical colleagues very closely, in that we use a lot of what they use as well. And sometimes they come and we do things together, so we can tell whether or not we're curing the seizures, or at least have a good idea of whether we're curing them by using these kind of techniques. We've operated on cavernomas with or without ultrasonic aspirators, and often, and I'm lucky, a lot of the patients that I've operated on have had to have a clear indication, so it makes a decision making easier. Or it may be that I've just waited until there was a clear indication. So what's the biggest challenge? So the biggest challenge really, and the bit that we all really struggle with, whether we say it or not as neurosurgeons, is the decision making when the indications are not clear cut. And this is something that we are guided by the patients and their families, and by ourselves and colleagues, and the literature that's available. And that's where it becomes tricky. And also not just the literature that's available, but being able to accurately interpret that literature and to make sense of it, essentially, and to explain it therefore to our patients, and to be able to be sold on the concepts of whatever's being published. So who's managing cavernomas? Local physicians, of course, and GPs, neurosurgeons and neurologists, and often they can be managed in the context of MDTs, multidisciplinary teams. That could be oncology, which deals with tumors because they are lesions. They're not quite, vascular teams often deal with aneurysms and arteriovenous malformations and lesions that can bleed with really high kind of pressure setting. Cavernomas, not quite the same, but they are looked after in a vascular MDT as well as epilepsy MDT. And it might be relevant in different units to have them under a certain MDT rather than others, or just have to have access to all three. So that's how they are generally managed. So who should manage them? This is, to an extent, my opinion, based on everything I've done so far, is, well, definitely those with an interest, those with knowledge and expertise in managing them. In an MDT, yes, or with an access to MDT. And by that is just to make sure that people can discuss with others. So to have a multidisciplinary, so being able to have a neurologist on board, to have a psychologist should you need to for various difficulty in decision making, to have the clinical nurse specialists, support groups, and so on. And we talk about that in a minute as well. For me in my practice, it's important that you have access to all of this in pediatric, teenage, young adult, as well as adult patients, and also the transition from the pediatric and what's called TYA into adulthood. So we said you have to have access to neurosurgery. So if you're not managed by a neurosurgeon, you should have access to a neurosurgeon. If otherwise you are managed by a neurosurgeon, you should have access to neurologist, neuroradiology, of course, and a unit where they are keen on looking at specific sequences that look for cavernomas, especially if you in the pediatric population, you need to look to see if there are more and if there are genetic mutations that have caused these cavernomas. And you guys have had, I think, a session earlier today on that specifically. Have access to neurophysiology to look at seizure activity or potential seizure activity, genetics, as we've said, psychology, clinical nurse specialists, and support groups. And I think the unique thing about cavernomas and patients with cavernomas is the support group, and there's a Cavernoma Alliance. And I very much say to a lot of other patients and patient groups that we are almost spoiled by having that and all the resources that are available through the Cavernoma Alliance. And if only we have more pathologies where there are support groups similar to the Cavernoma Alliance. And that helps us, because people often go away and look up things that we've highlighted to them, on the website, and then they come back and discuss this with us. And whoever's managing cavernomas needs to recognize that decision-making can be the most challenging aspect. And as you've heard Mr. Kitchen say earlier today, sometimes neurosurgeons tend to be very confident. So even when I think of the CARE trial, I think, okay, but which patients am I not going to be definite about a surgical intervention here or there? And there are patients that I come across that are like that. And that's a lot more prevalent in cavernomas. And a lot of the other pathologies I have, it's easy, because things are getting bigger. If you don't take them out, there's only one outcome, and it's not a good outcome. Therefore, anything you do is relevant. In situations like cavernomas and patients who are presenting with cavernomas, there's a lot more subtleties to that. So you have to recognize that sometimes you are very confident about not being confident at all. And in that situation, you have to take a step back and say, okay, well, hang on a second. What do we do? What do we do now? And what's the best way of managing this? And do we have time to wait? And the answer is yes, but it's all relative. Because there's a small risk of bleeding, but that risk of bleeding is real. And if that, if someone does have a bleed, then you feel that maybe you've missed the boat, you could have helped before. And that's the pressure that sometimes we are under, or we put ourselves under as neurosurgeons. And I've said whoever's managing should have involvement in or access to trials and knowledge of trials, because it's telling you that this person is up to date, is current, is always trying to do what's best, depending on what's published by others or by establishing trials themselves. So in terms of the neurosurgery aspect specifically, yes, the attractive thing about it is it can be curative. And certainly if you take the whole cavernoma out, the question is at what cost? Because anything you've done cannot be undone. It can be extremely complex, especially when you start talking about brainstem cavernoma. Even with a simple cavernoma surgery, and I know someone who used to say that there is no simple neurosurgery, the only simple neurosurgery is the neurosurgery performed by others, because anything you're doing and the simple neurosurgery can go wrong. Even if the operation went beautifully, people can react in very odd ways sometimes to our intervention. So it's important to remember that anything we do cannot be undone. So often I go into most situations and scenarios thinking, how can I avoid surgical intervention here? Carefully weigh up all options. As I said, always avoid if possible, because unless the risk of avoidance don't kind of outweigh the benefits, because obviously if someone's had a major bleed and it's causing a threat to life, trying to avoid surgery at that point is very clearly not the right thing to do. It's important for us as neurosurgeons, as clinicians, to know that we often guide patients in a certain direction or another, and to always be as neutral as possible, or if we're not going to be neutral, to say why we're not being neutral. And the other thing, and it's almost a cliche, and I always say it to my registrars, but there are various levels of saying, well, I would want this if I were the patient. But the reality is you need to really take a step back and put yourself in someone's shoes without projecting what your desires and wants and so on would be, but just to say, okay, well, if I were them with everything else that's happening in life, and I've had tumors, patients with tumors who have very slowly progressive and benign tumors causing trouble, but in a very minimal way, where they were achieving so much in their life at that time, where the risk of operating was too high for them to take, that I've completely supported them. And as an MDT, we've supported them to say, okay, well, let's hold fire and wait, and we'll reassess every year and see how things are going. So it's important when we're guiding to be aware of all this. And it's important that we do take time to try and say, okay, but if I were this person with this scan, with this risk equation, what would I do? And to recognize that sometimes it's really difficult to make that decision. And encourage second opinions, of course, and certainly don't discourage them. And that's pretty much the end of my talk. It's shorter than usual. I've elected not to have any operative neurosurgical videos. I thought that was the perhaps the wrong forum to discuss those, but ultimately it just talks about well, they summarize all the things that I've mentioned to you in words rather than in videos and pictures. So a very different presentation to what I normally provide. I hope it was okay with everyone. Thank you very much.